You're listening to In Good Health, the trusted news source for medicine, science, and technology. I'm Elizabeth Westfield.
I'm Mayan Vasta Betancourt.
And I'm Greg Johnson. This week, why women need to pay attention to their heart health as they age.
There's a lot that can happen where the arteries stiffen. Things like LDL cholesterol and apolipoprotein B can increase by up to 20% in just the few years around menopause.
But first, is a new primary care model changing the future of healthcare?
For a lot of these direct primary care doctors, these concierge doctors, they see that as a way to take medicine back from increasingly corporate and administrative oversight.
All that and more this week on In Good Health.
Dear McDonald's, your breakfast menu? Fire. 10s across the board. I could be happy with anything, even though I ordered the same thing every time. Thanks for not judging me. I'll try something new next time. Maybe.
Score a 2 for $5 deal on a sausage McMuffin with egg and more. Limited time only. Price and participation may vary. Cannot be combined with any other offer. Single item at regular price.
Ba-da-ba-ba-ba.
Hey, Sal.
Hank, what's going on? We haven't worked a case in years.
I just bought my car at Carvana, and it was so easy. Too easy.
Think something's up?
You tell me. They got thousands of options. Found a great car at a great price. And it got delivered the next day.
It sounds like Carvana just makes it easy to buy your car, Hank.
Yeah, you're right. Case closed.
Buy your car today on
Carvana.
Delivery fees may apply.
It's no secret that the U.S. has been facing a shortage of primary care physicians that's only expected to worsen in the coming years. Despite some proposed solutions like giving more responsibilities to nurse practitioners, accessing your local physician continues to be a big issue for many people.
In a lot of cities, including my city, Portland, the wait times for primary care are through the roof, and they've only gotten worse after COVID. And so you might see 6-month wait times. When you go see a physician, you might have to wait a long period of time to make that appointment or to make follow-up appointments. When you do go see them, you might not see them personally and be limited in terms of your time. And so you have to fit in lists and lists of healthcare concerns in a 15 or 20-minute visit.
That's Dr. Jane Zhu, a primary care physician and associate professor of medicine at Oregon Health and Science University. These significant barriers to care have carved a path for two alternative models to rise in popularity: direct and concierge primary care.
They are really focused on like sort of a monthly or annual fee. In direct primary care, this is a model where patients typically pay a monthly or annual fee, around $50 to $100 per month, without the physicians then billing insurance for routine care. So this is a model that operates outside of the insurance system entirely. And within that fee, you might have as a patient included in those services visits with your doctor, asynchronous texting or messaging with your doctor. There may even be labs or in-office procedures that might be included in that charge.
It essentially guarantees you quicker access to a physician than the traditional model. The concierge option is very similar, but Zhu says the fee is much higher, often in the thousands each year.
And it's more of a retainer model. So you're keeping a payment for the clinician in order to get better access to those doctors. And in the meantime, the doctors are still continuing to bill your insurance. So it is not operating outside of the insurance system. So the key differences are really one of cost and insurance use.
Zhu says these models have started to become popular with patients who want more personalized attention from their doctors. However, she warns against using the direct model as a way to completely bypass insurance. Between emergency room visits and specialist appointments, health insurance is still necessary. But with that said, she notes that some patients are starting to add direct or concierge care on top of their current plan to get the exclusive benefits.
they're choosing to pay an additional fee for improved access. And although the direct primary care doctor or the practice doesn't bill insurance, those patients still have insurance most often as a fallback or for other types of care. So you could see, this is sort of a layered model where the direct primary care doctor is charging a flat rate, and patients like this because it may be affordable. They're getting more frequent care, more accessible care, but you still have to have insurance in order to access care outside of that practice.
Though Zhu herself isn't operating in one of these alternative models, she understands why many of her colleagues have made the switch.
There is obviously a ton of administrative burden. We're burdened by short visit times. There's always time pressure. There's administrative and management pressures. There's burnout in these traditional practices, including the ones that I practice in. And so for someone who is purely clinical, I totally understand the draw for these new models of care.
Concierge practices started in the 1990s and often cater to patients with higher incomes. Direct primary care, on the other hand, is slightly newer and more affordable, but Zhu says both have seen a larger growth in recent years. Her 2025 paper, published in the journal Health Affairs, reveals that the number of these practice sites has grown by 83% between 2018 and 2023. The number of clinicians participating in direct and concierge models has also followed this trend, increasing by 78% in that same timeframe. Zhu says one of the main draws for clinicians is the freedom these alternatives offer.
I'm not in a community hospital, but I work in a very typical academic setting where I don't set my own schedule. I don't set the length of my visits. I very much have my practice influenced by administrators, as do a lot of physicians in practice these days. And these administrators are often, they may not be making clinical decisions, the decisions that I make with my patients one-on-one, but they are molding the conditions and the settings in which I practice.
In addition to the greater autonomy, Zhu says having a flat fee instead of a fee-for-service structure helps increase the time physicians are able to spend with patients.
If a patient comes in, there's nothing more that I would want to do than to spend an hour of my time with them and to build that patient-doctor relationship, to address all the concerns they're coming in with. If there's anything acute, to take care of those issues. In our model, the traditional model of primary care practice, I have 30 minutes. Often that's a long visit. Sometimes, physicians only have 15 minutes to take care of a patient's medical issues. You might know that just being a patient, as we all do. And so if you have the control of your schedule, of how you write your documentation, of how you bill, of how you charge, then that, for a lot of these direct primary care doctors, these concierge doctors, they see that as a way to take medicine back from increasingly corporate and administrative oversight.
Despite this push, Zhu's paper shows that direct and concierge care models aren't creating as much separation as physicians may hope. A key finding of her paper reveals that during this same time period of growth for independent operations, corporate-affiliated practices grew by more than 500%.
Corporate owners are increasingly owning these models of care, these practices, and potentially consolidating those as well. And so the reason this is, I think, worth noting and worth monitoring is because that might in and of itself change the philosophy and the incentive, the very basis of why these practices were formed in the first place as a response to these things happening across the healthcare system. And now that we're seeing that the same sort of ownership trends or the same organizational changes, structural changes might be happening in these groups of practices, I think that's worth monitoring over time because we want to make sure that despite those ownership models, or maybe because of those ownership models, we're not seeing changes in the way that clinicians are able to deliver their care, the pressures that they face, what they're charging, etc.
Along with tracking corporate influence, we need to continue to monitor where any cracks appear in this new system. While there's a lot of good that can come out of these models, Zhu says it's too early to really see the negative impacts.
For sure, some patients may benefit from having longer visits and better access, and physicians might actually stay in practice longer. They might have more professional satisfaction. They might have better autonomy. All of these things are really good. But when we look across the system, the healthcare system, what we need to keep track of and really monitor is whether increased growth in these membership-based care models could affect affordability or access for those that remain in traditional primary care.
A potential weak point is the workload of physicians. In traditional care, Zhu says clinicians can be responsible for up to 3,000 patients. Once they move to a concierge or direct care program, that caseload drops down to a couple hundred. It's great for those patients to have more personalized attention, but what about the thousands left behind to face the traditional system that's already experiencing a severe physician shortage?
So the questions that really come from these models and the growth in these models that we're seeing in the research is around scaling. What happens if you scale these models? We don't have enough providers to be able to provide everybody a DPC or concierge doctor. And so what happens to the patients who don't have the means or the ability to transition to these new models of care? One concern is that they will be experiencing even harder barriers with access to care.
Another main concern is affordability. Will access to quality primary care become something that's only available for those who can afford the retainer fee?
For everybody in the US to be able to afford a quality primary care provider probably requires a lot of structural change, both change with how we pay for services, where we pay for those services, and how we support our providers. All those things, anyone who's been navigating the healthcare system would be able to attest to the fact that that is not in place right now.
Zhu believes that as direct and concierge care models continue to expand, we also need to focus on building up the existing community-based programs that serve those unable to afford or access traditional care. You can find more information about Dr. Jane Zhu and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.
Coming up, does menopause worsen heart health? When In Good Health returns.
Okay, does this happen to anybody else? You sit down with a juicy QPC, some McNuggets, and those golden fries from McDonald's. Then you take a long sip of your Sprite because you can still hear your mama saying, "Don't fill up on that drink before you eat your food." But you're grown now, so you do what you want.
Share and share alike with a 20-piece McNuggets from McDonald's for just $6. Limited time only. Price and participation may vary. Cannot be combined with any other offer.
Ba-da-ba-ba-ba.
Hey, Sal.
Hank, what's going on? We haven't worked a case in years.
I just bought my car at Carvana, and it was so easy. Too easy.
Think something's up?
You tell me. They got thousands of options. Found a great car at a great price. And it got delivered the next day.
It sounds like Carvana just makes it easy to buy your car, Hank.
Yeah, you're right. Case closed.
Buy your car today on
Carvana.
Delivery fees may apply.
Though there's been an increased awareness around menopause in recent years, our knowledge of this life experience that happens to half of the world's population is still severely lacking. While menopause is often thought of as a reproductive condition, its effect on hormones has significant impacts on the rest of the body. In fact, scientists are now researching how this health event influences other areas such as the brain, nervous system, and cardiovascular system. Dr. Priya Freaney is a cardiologist and director of women's heart care at Northwestern Medicine Bloom Cardiovascular Institute. While there are various lifestyle factors that increase heart risk as we age, she says the biological changes that occur in women during menopause are a real threat.
By definition of menopause is the time when the ovaries stop producing estrogen. And estrogen is protective to the heart in different ways. So as that natural estrogen declines, there's a lot that can happen where the arteries stiffen, the cholesterol rises. Things like LDL cholesterol and apolipoprotein B can increase by up to 20% in just the few years around menopause. Blood pressures worsen, metabolism slows down so that it's easier to gain weight, body fat shifts to the belly. So all of these things together can drive this increased risk for heart disease around the time of menopause.
Research shows that this risk heightens even more for women who begin menopause earlier in life, which is at or before age 44. Despite this knowledge, many women are still unaware of the danger they're in as they enter this new stage in life. In fact, some of the telltale signs that something's not right are often overshadowed by the many common symptoms of menopause, such as hot flashes and sleep issues. Freaney says oftentimes women may not even realize the symptoms of heart disease for what they are because they can present differently in women than the ones we typically hear about, which are specific to men.
You often think about crushing chest pain, elephant sitting on your chest, which can happen in women. But other ways that heart attacks can present are nausea or shortness of breath or arm tingling or pain or jaw pain when you're moving around. A lot of people around menopause have palpitations or extra or irregular heartbeats that can be bothersome. That's something to look out for and talk about if it's bothersome to you.
A 2023 paper published in the Journal of the American Heart Association reveals that 1 in 4 women may develop irregular heart rhythms after menopause. This irregularity, called atrial fibrillation, can lead to blood clots, heart failure, and stroke.
And then going back to presentations of various types of heart diseases, heart failure, which is when the heart pumping function isn't working well and you can accumulate fluid retention in the body, can present leg swelling or trouble breathing when you're laying flat to sleep at night.
This difference in symptomology is important to know so that any warning signs can be caught early and treated appropriately. When discussing treatment, a question that gets asked is, what about hormone replacement therapy? HRT replenishes a woman's estrogen and sometimes progestin to help combat common symptoms like night sweats, bone loss, and hot flashes. And if it's the change in hormones that's ultimately causing many of these increased risk factors to heart health, shouldn't giving women additional estrogen fix those issues? Freaney says the various research surrounding this treatment has created a roller coaster of recommendations throughout the years.
Many years ago, it was that everyone should get it, then it was no one should get it. Now we sort of take a more nuanced, individualized approach of who to give menopause hormone therapy to and why. There's one, people say, your estrogen's declining and it's worsening your heart health. So if you just give estrogen back, shouldn't that solve the problem? But we have very clear data that says we don't treat heart disease after menopause with estrogen or with hormone replacement therapy. So we treat the risk factors and heart diseases in many other ways, but we can make an assessment of whether hormone therapy is safe for the heart if it's needed for other reasons like vasomotor symptoms, hot flashes, night sweats, sleep disturbances, things like that.
But Freaney says women who've already experienced a heart attack or heart failure are advised to avoid hormone therapy because it can actually increase the risk of blood clots, inflammation, and fat in the blood.
This is in individuals who have existing heart disease. This is giving hormone therapy back, right? Not natural estrogen, but giving hormone therapy back to those who have had heart attacks can change the vessel lining in a way that can propagate additional clot in the arteries.
Freaney notes that replacing natural estrogen with synthetic HRT is not an equal substitution. On top of that, additional hormones won't be able to fix the damage already done, such as high blood pressure, stiff arteries, and high cholesterol.
Symptoms of heart disease or the risk factors for heart disease have to be treated with other evidence-based methods that we have for that. So the cholesterol is treated with lifestyle and or cholesterol-lowering medications when appropriate. Blood pressure should be treated with lifestyle, sodium reduction, dietary changes, exercise, and blood pressure medications when needed. And there are other evidence-based approaches that we know work really well to lower risk factors and heart disease that we should, really hone in on more around the time of menopause.
Freaney says today, patients have a lot of options to pick and choose which treatment will work best for their individual issues. But while medicine has come a long way, she pushes for people to focus on prevention when it comes to their health, especially their heart health.
I tell all women that they can have a focused conversation with their doctors about mapping out their risk factors for heart disease at any point in adult life. It's never too early to have that conversation about what is your blood pressure, what is your cholesterol, what is your lipoprotein little a, if that's something that your doctor thinks is relevant to measure. What are your family members dying of, or what are the heart diseases that the family members have had? And how can all of that be taken together to map out a plan for you to treat or lower heart disease risk?
Since most women don't experience menopause until their late 40s or early 50s, it may seem unnecessary for women in their 20s to begin tracking their heart health. However, Freaney notes that heart attacks don't often come out of nowhere. It's usually an accumulation of risk factors that pile up over the course of 30 or 40 years, which means that what you do today has a direct impact on your older self.
So it's really never too early to start the conversation. We should start getting your blood pressure and cholesterol checked at age 18 when you're talking about adult medicine. And prevention conversations can happen at any time. When you talk specifically about menopause, I think that the decade prior is a good time to sort of brace yourself for the changes we've described about menopause. So in addition to cardiovascular exercise, which we all should be doing at least 150 minutes of every week, women should incorporate 2 days a week at least of strength training to get ahead of the muscle mass loss that happens at the time of menopause. Incorporating healthy eating practices prior to menopause onset if you can, so that it's part of your daily routine, so that when you have sleep disturbances and mood disturbances and don't have as much energy to be cooking well, it's already part of your practice and you can continue that. These are some of the tips and sort of timeline considerations about why it's important to get started early with bracing oneself for menopause and the changes that are to come, and not thinking that this is sort of the end of heart health, but rather a good time to take charge of your own heart health.
You can find more information about Dr. Priya Freaney and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our production manager is Jason Dickey. I'm Greg Johnson.
In Good Health returns in just a moment.
Okay, does this happen to anybody else? You sit down with a juicy QPC, some McNuggets, and those golden fries from McDonald's. Then you take a long sip of your Sprite because you can still hear your mama saying, "Don't fill up on that drink before you eat your food." But you're grown now, so you do what you want.
Share and share alike with the 20-piece McNuggets from McDonald's for just $6. Limited time only. Price and participation may vary. Cannot be combined with any other offer.
Ba-da-ba-ba-ba.
Medical notes this week. A breakthrough in mental health treatment is offering new hope for those living with schizophrenia. A study published in Nature Mental Health highlights the first new class of schizophrenia medication to be approved in over 50 years. Unlike traditional antipsychotics that block dopamine receptors, this new drug targets receptors that balance certain signals in the brain. Clinical trials showed a significant reduction in symptoms like hallucinations and social withdrawal. Scientists may have found the breakthrough for a flu shot that protects the community. A study published in Nature Communications reveals that boosting specific antibodies could significantly reduce a person's ability to spread the virus even if they become infected. Focusing on these overlooked antibodies could create a powerful layer of defense for those who are most at risk during seasonal surges and potential pandemics. Are vitamins the secret to male fertility? Chemicals in the environment can have huge impacts on reproductive health. Luckily, a study published in Environmental Science and Technology reveals that vitamin C can reduce some damage. In animal models, researchers found that while exposure to the chemicals found in explosives and fireworks alone led to testicular damage and a dramatic drop in fertility, taking vitamin C shielded sperm production and improved fertility. Scientists hope this research leads to better strategies for military and industrial workers often exposed to these contaminants. And finally, the thrill of the game may be fueling more than just team spirit. New data links legalized sports betting to a surge in local violence. In fact, research published in the Journal of Sports Economics shows that states legalizing sports betting have seen a significant rise in assaults, larceny, and vehicle theft on game days. The study suggests that the emotional volatility of betting, not just the financial loss, is a primary driver of this aggression. And that's Medical Notes this week. I'm Mayan Vasta Betancourt.
Okay, does this happen to anybody else? You sit down with a juicy QPC, some McNuggets, and those golden fries from McDonald's. Then you take a long sip of your Sprite because you can still hear your mama saying, "Don't fill up on that drink before you eat your food." But you're grown now, so you do what you want.
Share and share alike with a 20-piece McNuggets from McDonald's for just $6. Limited time only. Price and participation may vary. Cannot be combined with any other offer.
Ba-da-ba-ba-ba.
Thank you for joining us this week and every week as we break down the science stories you need to know. You can find all of our past segments and guests on our website at ingoodhealthpodcast.org or wherever you listen to your podcasts. Follow us on Instagram, Facebook, and X for more behind-the-scenes content. Tune in next week for another edition of In Good Health.
Okay, does this happen to anybody else? You sit down with a juicy QPC, some McNuggets, and those golden fries from McDonald's. Then you take a long sip of your Sprite because you can still hear your mama saying, "Don't fill up on that drink before you eat your food." But you're grown now, so you do what you want.
Share and share alike with a 20-piece McNuggets from McDonald's for just $6. Limited time only. Price and participation may vary. Cannot be combined with any other offer.
Ba-da-ba-ba-ba.